Thank you, ma'am. Thank you very much. Ma'am has already introduced our today's speaker, and we have the right person today here taking for us the PPH bundle. That's a person who has been working for so many years in the obstetric unit. So we welcome you, sir, and over to you now.
Thank you, Vedi ma'am. Thank you, Swati ma'am. Thank you, Rajsi, for this wonderful opportunity. Postpartum hemorrhage is this topic is very close to my heart, as me and my professor Dr. Fizvi is working on this PPH bundle since last 4 years. So it all started in 2016 when Dr. Thomas Burke visited our Sevagram, and there were 10 to 11 medical colleges involved, and with our Poonam Shivkumar ma'am, so many discussions were done. They had come up with the ideas, we discussed it, and with the technical support of WHO, uh, I'm very glad to inform you that we are a part of development of this module, that is comprehensive PPH care with the bundle approach. So I'll be talking about this through a PPH drill which we conducted in GMCH Nagpur, covering all this bundle. So before going to that topic, let's have a short brief review about postpartum hemorrhage. We all know that any bleeding post-delivery around 500 ml and post-LSCS around 1000 ml and above, we call it as postpartum hemorrhage. But then ACOG in 2017 has revised this definition of PPH, and any blood loss more than 1 liter, irrespective of the mode of delivery, we started calling it as postpartum hemorrhage. But with the presence of 50 years of anemia control program, still in India, we are getting more than 50% of our antenatal mother anemic. So this definition does not really apply to us. So the WHO has come with another definition, that is a clinical definition, that is any bleeding from birth of a rate or amount that has the potential to deteriorate the condition of the mother and cause hemodynamic instability and shock. So any bleeding post-delivery within 24 hours, which can make the patient hemodynamically unstable and produce hemorrhagic shock, is postpartum hemorrhage. Now, why the PPH is an obstetrician nightmare sometimes? So if you just go through the statistics, you will learn to know, you will come to know that even in developed country like USA, around 10% of women are dying due to postpartum hemorrhage of the total mortalities. Maharashtra is the second leading, as we know, in antenatal care. We have got around 98% hospital deliveries, and so the incidence of PPH leading to maternal death is 15%. But then this is not the scenario worldwide. In developing countries, in underdeveloped countries, more than 50% of the women are dying. Of the total deaths, 50% of deaths are attributed to postpartum hemorrhage. So when this review death committee has been set, and what they found that there are three delays in the mortality that is occurring in PPH. So what are those three delays? The first delay is delay in diagnosing postpartum hemorrhage. Most of the time, PPH is diagnosed when the hemorrhagic shock is already set in. The second delay they found it is the delay in implementing all the comprehensive care, and the third is there is no proper use of these comprehensive care. So these three things are responsible for deaths due to postpartum hemorrhage. So now to address this issue, WHO has come up with this bundle approach. Now just to tell you about what exactly this bundle is, I like to quote a very old story which has been told all of us by our grandparents. There was a man who is on the deathbed. He had 5 children. He called all of them. He just want to show them the what is mean by strength. So what he brings 5 sticks, give 1 stick to each, and ask them to break it. Everybody easily breaks those sticks. But then he collects the sticks, he makes it into a bundle, and then he distributes to all the 5 sons. And then this time they are unable to break it. So this is the effect of bundle. When the things are utilized in a complete manner, in a proper manner, we get good results. So bundle is nothing but the evidence-based uh, evidence-based strategy to to treat a particular disease. So in postpartum hemorrhage, last slide. This is the bundle. So I'll be telling about this bundle approach through the PPH drill. Now this is what has happened in PPH care. In 2009 we have got red coat strategy. In 2011 we got a transfusion policy. In 2013 the anti-shock garment, the UBT and compression suture were used. In 2015 we have got checklist, and 2017 onwards PPH bundle approach has been done. This is a slide from Kali Hospital, Colombia. She is one of our colleagues who has instrumental in forming this PPH bundle. So let's go with the PPH drill. This is the GMC ward, and
give us a minute, please. Huh? Yeah.
The rounds are going on, and during the rounds, PPH was detected.
Even faster. Faster. Can you all see the video well, Swati?
Yeah, ma'am. We can right now.
Swati?
We can see. Yes, yes, we can see.
Just
start that.
Video is seen well.
Ma'am, as of now, we can see only the still picture.
Swati,
yeah, ma'am.
Yeah, we paused it. Can you? Okay, okay.
Now, how to make a diagnosis of postpartum hemorrhage? I must not tell you, you all are aware of it. It is visual estimation of blood loss, which is the only sign which is there. Most of the times, when we ask for PG, what are the symptoms and signs of postpartum hemorrhage? So tell us the symptoms and signs of hemorrhagic shock. So please remember, there is a wide gap between diagnosis of postpartum hemorrhage and development of hemorrhagic shock. So there are no symptoms of postpartum hemorrhage except some vague symptoms like giddiness, weakness, and visual estimation of blood loss. Now, the evidence says that in 2/3 of the cases, this estimation of blood loss is not proper. The obstetricians, they had a tendency to underestimate the blood loss. So please, there are various platforms where there are various charts, there are flow charts. So I request all the obstetricians, please try to make an overestimation of blood loss and try to diagnose postpartum hemorrhage early. And there is definite role of postpartum monitoring. The evidence says the uterus should be palpated every 15 to 20 minutes for first 2 hours. So I don't know how many of us are really practicing that, but then postpartum monitoring and early diagnosis of postpartum hemorrhage is very, very important. Then the second thing which is important in PPH is call for help. You cannot manage PPH alone, and even don't try to manage PPH alone. So there has to be a team. You must have your own individual team. The team has to be individualized. There must be 4 members in the team: the obstetrician, the assistant, an informer, and a supplier. So these 4 minimum things, the 4 minimum people has to be there in your team. So you have to form your local teams, as Dr. Vaidehi ma'am has come with this idea of WhatsApp group and a development of teamwork. Then definitely this is going to help us. So you have heard the buzzer which we have put in our both the labor wards. You can call for help by many ways. You can put a buzzer, you can call by telephone. And now, as in this COVID era, we all know that the prevention is the best treatment. So AMDSL is the very good tool in management of postpartum hemorrhage. So we must prevent PPH by AMDSL. AMDSL has to be done in all the patients, irrespective of the high risk or low risk. So it should be practiced in all AMCs. There are 3 components of AMDSL. First is oxytocin, that is 10 unit oxytocin intramuscular. You can also give injection methargine, or you can use tablet misoprostol 400 to 600 per rectally. The second thing in AMDSL is control contraction. We know it very well, so you have to push the uterus slightly up and give a gentle traction over the cord with after 1 to 3 minutes of cord clamping. And the third component is uterine massage. So it should be a gentle massage in a circular manner, in a clockwise direction over the fundus of the uterus, and pushing it slightly downward, so that if there is a blood clot in the uterus, it comes down. So this oxytocin 10 unit intramuscular plus control contraction and uterine massage forms 3 components of AMDSL. Yeah, so So now this is an emergency scenario. The adrenaline is rushing up, and people are frightened. And this happens to our staff also sometimes. So we must use communication tool properly. So this is one closed loop communication tool which can be used in this emergency scenario. So what I have asked for, I have asked for 20 unit oxytocin in drip, and my staff nurse has come back to me saying that 20 unit oxytocin has been put in the drip. So this closed loop communication helps in effective management or effective response. Now, this is the missing part in any postpartum hemorrhage care, that is consent and explaining the risk. We are so busy in managing the patient. We are usually short of staff, short of hands, and then nobody goes out and talk to the relatives. So counseling the patient, counseling the patient's relatives, telling that things will be all right, and telling them about the future course of treatment, it is very, very important. Now, ordering blood and blood products. So as soon as the patient, you diagnose postpartum hemorrhage, please make it a point that you arrange blood at least. Arrange blood, arrange FFP, and issuing it. When did you receive the blood? That is very important. Many times the blood is received when already hemorrhagic shock is already been set in. So as before the hemorrhagic shock sets in, your blood and blood product must arrive. So the timing is very important, and it actually depends on your setup. So if you had blood bank far away from your place, then definitely you must know how much time the blood is going to come. So according to the patient's condition, you have to individualize this decision of ordering blood and blood products. So in a country like us where anemia is so prevalent, issuing one blood, like this is a very common practice in our setups. So I personally advise there is no harm in issuing one blood and giving it, because anemia is so much prevalent. We get so many cases of mild to moderate anemia, and one blood suffices sometimes. But then we have to issue blood according to the patient condition, and blood and FFP has to be given in 1:1 ratio, and please give it before session. Now, this is the actual treatment of postpartum hemorrhage, the first bundle. So there are 4 components of first bundle: uterine massage, which I already explained with ANTSL. Now about IV fluids. We all give IV fluids in postpartum hemorrhage. The ringer lactate and normal saline is the IV fluid of choice, right? But then how much to give, when to give. So as soon as you diagnose PPH, IV fluid must be started. There is no doubt. There has to be 2 large bore IV cannulas. Blood group cross matching sample has to be removed. From one side, oxytocin 20 units should be given, and from other side, IV fluid should be given. About IV fluids, I like to mention 2 points. One is, if your aim is to stop the bleeding, right? So just the patient is bleeding, you are giving IV fluids, the BP is falling, you are trying to increase the BP by giving IV fluids, by pushing IV fluids. This is not going to solve the problem. This is going to increase your problem because of dilutional coagulopathy, which is created by excessive use of IV fluids. So for 1 liter of IV fluid, after the bleeding is controlled, we have to give around 2 to 3 liters of fluid to take care of the intercellular as well as extracellular compartment. But if there is no active bleeding, the bleeding has been stopped, definitely 2 to 3 liter IV fluids are given. But if patient is bleeding continuously, then 500 to 700 ml IV is enough. After that, you have to start blood and blood products. Right. Now about the third component, that is uterotonics. We must not rely on one uterotonic. So our common practice is we give 20 unit oxytocin in drip. We may increase the dose up to 30 to 40 units Drip rate should be around 40 to 50 drops per minute. We can use injection methargine 0.4 mg IV. The evidence says 0.2 mg intramuscular, 2 to 3 early for maximum 5 doses. But we are using 0.4 mg IV, and then we can repeat the dose after half to 1 hour, 0.2 mg intramuscular. Prostudine 250 microgram has to be given and can be repeated 15 to 20 minutes later. Can be given up to 8 doses. Tablet misoprostol, if not already used in AMTSL, we can put 800 microgram per rectally. So we should not wait for the action of one uterotonic to come. So we can use 1 or 2 uterotonic depending on the patient's condition, and of course it should there has to be, it should not be contraindicated. Like methargine should not be used in severe preeclampsia, heart disease, and severe anemia less than 4 gram per cent. Prostudine should not be used in asthma. So we all have to take these things in mind and use oxytocin to its highest dose. And the fourth thing is tranexamic acid. As per WHO recommendation, injection tranexamic acid 1 gram, 1 ml per minute, slowly in over 10 minutes, has to be given in every case of postpartum hemorrhage within 1 to 3 hours of delivery. And we can always repeat a second dose after 3 hours. So this is the first bundle. You have to give massage, you have to give IV fluids, you have to use oxytocin, and you have to give tranexamic acid to each and every patient of postpartum hemorrhage unless contraindicated.
Ashish, just want like to interrupt. Friends, in the chat box, do not post messages about ICOG credit hours right now. There's a very clear message we'll post. We'll give 2 numbers. You have to send a message on those 2 numbers. So don't flood the chat box with your ICOG credit point details. We'll post a message number. Secondly, post all your questions at the end of the talk. Otherwise, we'll miss out the earlier questions. So don't post the questions now. It's possible that all your queries may get solved during the presentation. All right? Okay, Ashish, go on.
Now, there are various supportive measures we must do in each and every case of postpartum hemorrhage. So, what are those supportive measures? The first is checking for vaginal and cervical tears. So, there is no sequence that we should do supportive measures first or we should do bundle approach first. We can use either or. So, checking for vaginal and cervical tears and rechecking is also very important. Many times, what happens is there is a gush of blood and the vaginal and cervical tears are missed. So if the bleeding is controlled or reduced, you can just see for, you can take a second chance to see for vaginal and cervical tears. The second thing is emptying the bladder. Putting a Foley's catheter is not a right idea in each and every case of postpartum hemorrhage. In mild cases, just giving a squatting position and asking her to void urine will take care of your full bladder. So as we know that full bladder is itself responsible for atonic PPH and squatting position, emptying the bladder will help the uterus to contract, and it also will help the clot to pass. The third is emptying the uterus. So there's various controversy on this part, emptying the uterus. Some people say that we must not put our hand inside the uterus, but then the evidence says we can empty the uterus. We just have to consult the patient. We may use mild analgesics. Put your hand over the uterus, and with the other hand you go up to the fundus and try to remove the clots whatever is there. So these are the supportive measures. This fourth more supportive measure which can be done is putting the baby to the breast.
It is recorded.
So is there any audio going on with the video? We are not able to hear any audio.
Can you listen to the audio also in the video?
No, sir, no.
Sorry?
We are not able to hear any audio. It's just the video which is going on.
No,
Acha,
there is actually audio and the video also.
Okay, so I think along. No, ma'am, no, because sir was pausing it between, no, so it wasn't that obvious. But right now we are not able to hear anything. I think, sir, side by side, you can just explain the procedure.
Right. So, as the first bundle has been done, the supportive measures has already been done. The patient has continuous bleeding, and vitals were deteriorating. So we have to go for second bundle management. So there are three components of second bundle management. One is the compression measures. So as obstetrician, we all are aware of bimanual uterine compression. We have to put a piece anteriorly and we have to compress the uterus over this piece. So this will give compression over the vessels, and this is a temporary measure to control the bleeding. Then if you are planning to transfer patient from labor room to OT or from one place to other, you can do the another compression maneuver, that is aortic compression. So just slightly to the left by the side of umbilicus with the feast, thumb inside, you put it over the umbilicus just slightly to the left, and with the other hand you palpate the femorals. So this looks easy, but then it's not that easy. It's a difficult thing, and definitely the bimanual uterine compression gives you good results. But while transferring patient, you can always do this. Give a aortic compression, see for the femoral. The femoral should get muffled, and then with this you can transfer the patient from one place to other. The second thing is in second bundle is uterine balloon tamponade. So this is a ESM UBT. Can you see this, Swati?
Yes, sir, we can see that.
ESM is every second matters. Every second matters UBT. This has been devised and used worldwide. This is just like a condom catheterization. If you remember, we used to do it in our old days, the Foley's catheter along with condom. So there is a specially designed catheter which is a bit rigid compared to Foley's, so it doesn't come out with the blood. And then there are condoms tied to it, and the condoms are inflated with around 250 to 300 cc. Usually that suffices. But as soon as the bleeding stops coming, you stop inflating the condoms. So there are two tubings attached to this catheter, and from one there is a balloon inside the catheter. So that's like a Foley's catheter. So this balloon is a self-inflating balloon and self-detaining balloon, and the condom gives adequate pressure over the uterine vessels to make the bleeding stop. So this is used for whenever there is active bleeding, despite of using first bundle. And the third important tool in this second bundle is anti-shock garment. So I have demonstrated this garment in the video. This is made up of neoprene material with Velcro flackings attached to it, and there are 6 segments. We have to start from lower down, 1 to 6. On the 5th segment, there is a ball which compresses over the uterus and gives additional pressure over the uterus. We can do massaging with this NASG in situ also, and we can do many surgical procedures also along with this. Even we can do a laparotomy or even cervical exploration with this NASG in situ. So NASG is just like it increases the blood pressure to the vital organs by compressing the vessels lower down, and it is actually used to treat shock, and it is less used for the controlling blood pressure, controlling bleeding. So these 3 things, compression measures, uterine balloon tamponade, and NASG, makes the second bundle. So here it's not mandatory to use all 3 components together. Just like in first bundle, we have to use all the 4 things unless it is contraindicated. So here you can use either or. You can use compression measures along with NASG, or you can use uterine balloon tamponade with NASG. And since last 2-3 years, we are using this NASG and uterine balloon tamponade in postpartum hemorrhage in GMCH, and we have got very good result. So the worldwide hundreds and thousands of UBTs are used, and this second bundle is definitely going to help patient in going into hemorrhagic shock. So now the patient is, the uterus is hard, patient has responded to the bundle, but this is not going to be the case in every scenario. In 1% of the cases may not respond to the medical management and your bundle approach. So you may have to think of surgical management at any point of time. After using first bundle, simultaneously using second bundle, you can think of surgical management. So about surgical management, it's a very big topic, and I request Vaidhi ma'am to take another
that's going to be the next session.
webinar on surgical management of PPH. About this bundles, what is my observation is that if the abdomen is open and patient is bleeding, then it's always better do you use the surgical management. But after delivery, after post LSCS, if you diagnose PPH, then you must try all conservative management, including these Parikers cannula and specially devised the forceps, which yes, Piley's forceps, which is applied to the cervix, and that clamps the descending branch of uterine artery. So all these things can be used. You must try. But then there is a definite role of surgical management of PPH, and the timing is very important. You must not make the irreversible damage to the patient, and before the irreversible damage takes place, you go with the surgical management. And you are an obstetrician. Never forget, you are an obstetrician.
Yes. So we have already planned the surgical management module in the next 2 weeks. Yeah.
Sound audio is visible, Swati? Audio. Swati, is there audio?
Sir, audio is not clear.
Now, at the end of this procedure, we are going for a checklist. This PPH bundle has its own checklist. There are so many checklists nowadays used by hospitals. But then this checklist is very important, and you must do after every procedure. You must do the checklist, and just show the checklist.
So this is over video?
Yes, this video is over.
Okay, go on.
What is the checklist?
Next slide.
Next slide.
Stop कर play.
So I'll just share this checklist with you all people. So this is the first response bundle.
We should go.
IV fluids, uterotonics, tranexamic, uterine massage, then the response to refractory PPH bundle, the compression performed, the uterine balloon tamponade, anti-shock garment. And also you can see for the other supportive measures.
So they can take a screenshot because recording will be available a little later. So please take a screenshot of this checklist. We'll just pause for a second. Yeah.
Now, just merely managing postpartum hemorrhage is not going to reduce the morbidity and mortality due to postpartum hemorrhage. This is what the WHO says. So WHO has come with this other non-clinical components of PPH management also. So this is teamwork and communication. We had worked on this teamwork and communication with our referring centers, and we got very good results. I'll share that experience with you all. And the second thing is facility readiness. Your facility has to be ready for the postpartum hemorrhage. So, you know, if you had 100 delivery per year, then around 2 to 8 postpartum hemorrhage cases will come in a year. But then many times our response depends on how ready our facility is. So teamwork, communication, facility readiness is very important. About network integration, this is actually applied to the government hospitals like PSCs, CSCs, and district hospitals with tertiary hospitals. But then this can be private hospitals can also integrate themselves. Like PPH, I told you, is like not a very common thing which comes in day-to-day life. So you can make 3-4 nursing homes. They can come together. They can plan something like a team, and they can integrate their hospital. They can buy one NSG. Like 4 people can buy an NSG and can transport it. So something of that kind can be done. So this is our experience. We were getting very bad patients from District Hospital Bandara and Daga hospitals. So they were contributing to around 30 to 40% of total referrals and around 30% of total mortalities. So we started communicating with them. We trained their staff. We trained our staff in communication. We formed a rapid response team, and these are certain success stories of that project. So I'll tell you in short about this facility readiness.
Volume hai abhi? Volume?
Voice is there, Swati?
No, sir, not clear. Not at all.
So this is the PPH bundle tool. The AMTSL is on the top. The second thing is call for help. The first response is IV fluids, uterotonics, tranexamic acid, and massage. And emptying the uterus. And the second response to refractory balloon tamponade and NSG, and other supportive measures like giving blood and blood products, and thinking of transferring from one hospital to other if your hospital is not well equipped with further management.
मैम नहीं है ऑडियो नहीं सुनाई दे रहा कुछ.
So it's not like we always go for first bundle and then go for second bundle. If patient is diagnosed late, then we can straightforward go with the second bundle and do first bundle simultaneously and supportive measures simultaneously. So there is no sequence of using these bundles. You can, depending on the patient's condition, you straightforward goes with an NASG. Patient is in shock. So the take home message is prevention. You have to do you have to screen, you have to take care of anemia during antenatal period. You have to you practice AMTSL in all over your patients irrespective of the risk. You have to use first bundle supportive measures, and you have to be ready with the second bundle in case if things doesn't go as planned. And then definitely there is a definite role of blood and blood products and planning to shift patient from one facility to other. Now about facility readiness, I like to share this video with you. This is from GMCH. We have got a PPH trolley which is equipped with all the required material. That all the things are in one place, because many times PPH takes place and we have to just run for things. So this should not happen. All the things has to be there. There has to be a PPH corner. There has to be a PPH tray or something like a PPH trolley, and then there has to be a checklist. The checklist has to be maintained and seen by your staff nurse, daily updated, or a particular time of a week or a month. It has to be updated. So this is what we are doing in GMCH. This is our PPH trolley, and this is the checklist which is maintained by our staff nurse. And all these small measures has really helped us in decreasing this morbidity and mortality due to a killer. So this is my team with GMC who has helped me in PPS drill, Dr. Smruti, Bharat, Namrata, Shilpa, Ashish, Amrita and Bharti sister. I like to end my presentation with this poem which is written by our own Humne sir. Dear PPH, you are horror of my life. Reluctantly, I part of this turmoil. PG-led excitement upon meeting you, charged with energy, determined to defeat you. I barged in like an uninvited guest. You barged in like an uninvited guest. I sympathized with this unavoidable quest. At times, I greet you with blood bank, but you don't turn up when things are in my hand. Turning my sleep into nightmare, I have joined my hands with NSG misoprostol for peaceful welfare. Placenta previa, accreta, atony are your reasons. I present intensivists, pathologists for action. My state is inexpressible. Encounter with your visit shocking and terrible. Why do you haste 2 minutes and time? Your pace from pink to pale. No time to consent and relatives to tell. I won't befriend you and make my rival, but I would not sacrifice for mine and patient survival. So this is all about PPH management with bundle approach, and I invite questions from you, and I'll be very obliged to answer your questions.
Thank you, sir. Thank you very much. It was a really very informative talk.
And I'm extremely sorry for the audio in the video, but then here we were listening it very properly.
Yes.
Okay.
It was very clear.
Okay.
Okay, so I'm just going through the questions. Yeah, are we supposed to, the first question, Ashish, are we supposed to get consent for all the deliveries mentioning PPH or any model consent form that you have?
No, actually you should not. If the PPH has taken place, then somebody must go out and talk to the relative and tell them about that this has happened and this is what is been done to the patient, and this can be the further consequences. Like we may have to give blood, we may have to go for surgical. So somebody must go and talk. What you can do is you can just ask the relative to peep into the labor room and can have a personal 1:1 dialogue, because many times it comes into medical legal things, and relatives says that we are not been explained, and then if something if mortality occurs, or if you have to transfer patient from one center to another place or an ICU, then the problems arise. So informing the relatives and taking consent after PPH is important.
Yeah.
But in every delivery, it should be a routine consent for delivery.
Dr. Rupali Deshpande wants you to demonstrate the use of UBT kit.
Yes.
Can you do it?
Yes.
So,
Rupali, if you could give me, this is the ESM UBT kit. This will be now developed by HLL and soon will be available to private practitioners also. It is actually we have actually planned it to give it to AMs and all peripheral workers who are conducting deliveries, because many times what happens in institute, in GMCH, we are seeing that the PPH is killing only 6% of females, but then Maharashtra statistics said it is 15%. So most of the females are dying either on the way or they are dying at a peripheral health centers. They are not dying at the institutes. So this is actually devised. This is a very simple device and device so that it can be used even by ANMs. So there is a syringe here. This syringe is it snugly fits into this catheter and it gives a very easy push. You can just push 200, 300 in seconds. So this is one benefit. Then you had gloves. You had these condoms, 2 condoms in the kit. So you don't need to put 2 condoms, but then if one ruptures, then you may have to put another condom. So this is the catheter. This is a rigid catheter. You see when the Foley's has been put, the Foley's comes out. You may have to put 2 or 3 Foley's at a time. But then this is a rigid catheter and it goes easily. You have to place it up to the fundus, but before putting it, you have to put a condom catheter over here. I can demonstrate you that. So when you are managing postpartum hemorrhage, you can always ask your staff nurse or your assistant to prepare this UBT. So while preparing this, just make sure that the major part of condom lies beyond the tip, because you have to inflate that uterine cavity with the condom. So condom has to be there distally. This is a rubber band just to demonstrate, but then you can always put a thread or anything, whatever is available. And these are not sterile things. So just please remember that you have to give a single shot of antibiotic after you put this. These are the two cannula. These are the two tubings. So from here you put the normal saline, and here you inflate the bulb.
Swati, is it visible well? Are you all able to appreciate
Yes,
it
ma'am.
well?
Yes, ma'am.
And there is a checklist here also, which can be used while using this.
So is that clear?
And then about removal, you can keep it up to 12 hours. 12 hours, and after 12 hours, you can you can deflate it by around 100 cc. And if there is no bleeding, then you can completely remove it. Some people practices it like every 100 cc, one early or two early. So, but then guidelines say you can just to remove 100 ml, and then if there is no bleeding, in the next 1 hour you remove the whole of the UBT.
Okay, so you already answered it. This is not available commercially right now. Is it available commercially?
It will be soon available, and HLL is working on it.
So can you give an estimate about the pricing? How
I think they have kept it in the range of, first they told it will be around 250, but then I think they have said is 400 or something.
So very reasonable in fact.
Yeah, it is a very cheap option, and it is a cheap alternative to the Bakri balloon. The problem of Bakri balloon is that it doesn't go so easily, especially post LSCS.
Okay.
So and Bakri balloon works on a high pressure, low volume principle. This is a high volume, low pressure balloon.
Right.
So that's why there is no third cannula to take care of the inside collected blood. Blood doesn't collect actually. It comes out from the sides if it is there.
Correct. Someone wants you to share the tabulated slide and PPH bundle slide which you are holding. So maybe you can do it later. On the PPT, do you have that slide?
It is there in the PPT.
We'll show it at the end of the session. Yeah. So what is the reliability of injecting saline solution in umbilical vein in cases of retained placenta?
Injecting saline solution.
Yeah.
In retained placenta, you must take the patient to OT and try for manual removal. I personally don't agree with this method of treatment.
Someone wants you to share the PPH tray again. So can we just show later?
Yeah, why not?
So remember, we'll show that video later again. So we'll just freeze on that visual. Are we supposed to get, oh no, this is covered. Can you please tell us that what combination of uterotonics in all your low risk patients?
In low risk patient, we usually start with oxytocin. We give 20 unit oxytocin for treatment, 10 unit oxytocin for prophylaxis. So please remember this dose. 10 unit is for prophylaxis. If there is a PPA, you have to go for high dose. So 20 unit is a starting dose. You may go up to 40 units. 13.4 mg IV. And give injection prostaglandin 250 microgram intramuscular.
What about prostaglandin intramyometrial?
Intramyometrial during LSCS, yes, you can, but during normal delivery, I think it should be given intramuscular. You should not try intramyometrial. So that is the only concern.
Right. What is the dose of tranexamic acid?
It has to be 1 gram. So it is 10 ml per minute is the dose. So 1 gram is the standard dose. Okay. And it has to be given within 1 to 3 hours of delivery.
Achha, all right. Within 1 to 3 hours of delivery.
Yeah.
Given the of how much
time of tranexamic acid is really debatable. If you want to use tranexamic acid,
should be used
give it bit expertization. But then it could be one alternative to balloon tamponade. But then please remember, the women are dying where this where the expertization is not available. So this UBT is a low-cost, user-friendly device.
Okay. Is prophylactic dose of misoprostol recommended in all the deliveries or only in high risk patients?
You can use it prophylactic as a part of AMDSL. You can use either oxytocin or tablet misoprostol. So if you don't want to use oxytocin, you can just simply use 400 to 600, well, 2 or 3 tablets of misoprostol per rectally. You may not need to use oxytocin.
Okay. Have you used SR cannula?
Is it different from panicus cannula? Even I am hearing this for the first
Dr.
time.
Bala wants to know. I think if he's still there, he can unmute himself and tell us. How to get tranexamic acid? IV, any specific dose schedule for that?
1 gram IV. It has
So
to be
slow-
given IV. Slow
slow.
over 10 minutes. 1 ml per minute is the dose. So slowly over 10 minutes.
Over a period of 10 minutes. Okay. What is the dose of misoprostol? Is it 800 micrograms or less? But immediate postoperative many develop high temperature.
So this is the problem with misoprostol. You have to be ready for a temperature, but then it's manageable. So 800 microgram is the dose for treatment of PPH, and 400 to 600 is for prevention of PPH.
In WHO guidelines, they have asked to continue 500 ml normal saline after every hour. But Dr. Ashish has mentioned to stop after 500 to 750 ml of normal saline and start blood. Can you please elucidate?
Yes. So there is something called as bolus treatment for management of bolus treatment of IV fluids. So these bolus should not be 500 ml. It should be 200 ml. So you can give 200 ml, wait for 30 minutes, then give another 200 ml, then wait for 30 minutes. So this bolus treatment of IV fluid is one treatment. See, problem with IV fluid is that it's going to produce dilutional coagulopathy if bleeding is not stopped. So if the bleeding is stopped, then definitely you can give good number of IV fluids. You can give up to 2 liters, 3 liters of IV fluid, because that is needed. If you are not planning to give blood transfusion, hemoglobin is good. But if there is a active bleeding, then not more than 500 to 700 ml. After that, you have to give blood. You give 500 to 700 ml and start giving blood, and try to control the bleeding.
Okay. What's your choice of misoprostol route, sublingual or rectal? What is your preference?
Rectal is always good. You can go for sublingual, but then we are using it rectal.
What's your opinion about pre-oxygenation during labor or LSCS as a prophylaxis to prevent PPH?
The use of oxygen in PPH comes very last. It has to be a part of ABC of resuscitation. So if patient into hemorrhagic shock, you have to plan the basic steps of resuscitation, that is airway, breathing and circulation. So that knee-jerk reaction of giving oxygen in postpartum hemorrhage, it's a waste of time. Please don't practice it. It's really not recommended.
All right. IV direct oxytocin in PPH? I don't know what she wants to know.
She must be saying about IV bolus oxytocin.
Okay.
IV bolus oxytocin should not be practiced. The deaths have been reported. The cardiac problems have been reported. There are cases of sudden cardiac deaths due to IV oxytocin. So recommendations are not at all in favor of IV oxytocin bolus. You always have to give in drip.
Okay, great. Dr. Chaitanya wants to know, I think you answered that. Do you think condom catheters are better than Bakri balloon? So you already answered that.
Yes.
It's better.
Cost-wise, it is good. Then if you had a USG machine, and then definitely you can see the good spread, and you can see by your own eyes. That is, you can put it USG guided also. So the condoms catheter are definitely better than Bakri balloon.
Okay. Bakri balloon and surgical uterine artery ligation combination, is it helpful? Combination of uterine artery ligation surgically and a Bakri balloon.
Yes, it helps.
So
when the abdomen is open, then you can go for any combination.
Okay, how much do you inflate the UBT with?
You can go maximum up to 1 liter, but then usually by 250 to 300 ml, the bleeding stops. Many times we have to go with 500 to 600 ml, but then maximum capacity is 800 to 1000 ml.
And the role of PPH cannula on
so you should
suction
stop
cannula.
putting normal saline as soon as the bleeding stops. So that is a cutoff limit.
Sure.
If the bleeding stops, you stop putting further normal saline.
Right. Role of PPH cannula and suction cannula you've already mentioned.
Yes.
Panicas and
it has its role. It needs expertization.
Right. Maximum dose of pitocin that we can give?
You can go up to 40 units. Max is 40 units.
So only oxytocin or oxytocin plus meso?
You can use any combination. If you started with oxytocin, you think she is still bleeding, you can go for meso. If you think still patient is still bleeding, and you should, the important thing is you should not leave the end of the patient. You have to be at the vaginal end all the time unless the bleeding is stopped. So this is a big mistake we do many times. We leave the patient and the problem comes.
Yeah, so they all want to know the commercial name of UBT. You have already mentioned it is not yet commercially available, but it will be available.
It will be available with the name of Vayu ESM UBT. ESM may go, I think, Vayu UBT.
Okay, what combination do you give to every patient as prophylaxis if there is no contraindication?
Only 10 unit oxytocin intramuscular.
Okay, so do you think we should give routinely tranexamic acid in all LSCS cases?
And the extension to it, if oxytocin needs to be refrigerated. So places where like ANMs are delivering or PSCs, you go for methargine or misoprostol. Misoprostol is preferred or methargine for peripheral centers.
So next question is that should methargine be given as a prophylaxis or only therapeutic?
It can be used 0.2 mg intramuscular after 1 minute of delivery, after 1 minute of clamping the cord. Intramuscular for prophylaxis.
Okay. Every patient blood product result is it necessary?
No, not at all. So PPH can be unpredictable sometimes, but then you usually get plenty of time. If you there are so many measures, so many good measures to control the bleeding. So her hand and remove it. But then post LSCS, many times this removing the blood clots will be helped. But then Parikkar's cannula has a special device, so that is actually used for postpartum hemorrhage.
What's the role of vitamin K? Is there any role?
No, there's no role of vitamin K in management of PPH. It can be used when there is a pre-existing liver diseases. So that is why it is kept in that PPH tray, because you never know. The patient may come with jaundice so in that patient you may have to give.
What's the role of injection Trenexa as a prophylaxis before cesarean section in high-risk patient?
This has been there are no this has been common practice, like giving tranexamic acid 500 mg in drip before skin incision. So you can use it.
All right. Dr. Bala has mentioned that SR cannula has different dimension cannulas for normal delivery, LSCS and MTP. And many of us in Madurai, they are using it and it's working really well for them.
Great.
Okay, there are lots of congratulatory messages for you, Ashish, in the chat box for a very wonderful presentation. Does misoprostol intrauterine work, although not recommended in books?
No, it is not at all to be used intrauterine. Misoprostol has to be used either per rectally or can be used sublingually.
Okay. What is the blood transfusion protocol of your hospital in atonic PPH?
Yes, so we usually get blood in 10 to 15 minutes, except in exceptional scenarios like change of duties around 2 p.m. and 8 p.m. and sometimes in the 2 a.m. or 3 a.m. time. That time we get difficulties, but otherwise the blood readily comes within 15 minutes. We are not using O negative blood for massive obstetric hemorrhages. Last year we got around 80 cases of massive obstetric hemorrhages, and there are just 4 mortalities. So even in those cases, we have to use blood and FFP in combination. So blood FFP ratio 1:1, and if patient goes into massive, then you have to add platelets, cryo, and other factors.
So is there any formula or
blood and FFP in 1:1 ratio?
Okay. Can we give IV iron on day 2, day 3 after the cesarean section, after the delivery? Can we give IV iron on day 2, day 3 after managing with blood transfusion earlier? Are there any side effects?
Yes, you can use even FCM post delivery. It has been recommended now. WHO has not recommended, but then it's been common. FIGO has recommended, FOXY has recommended, and we can use it. Like you can give a IFCM on day 2 or day 3 if patient had moderate to severe anemia. Especially after normal delivery. Post LSCS, you prefer blood transfusion because the healing and the wound part will be taken care by that.
Is UBT a substitute for uterine packing?
Uterine packing is contraindicated. You should not do uterine packing in any circumstances. So packing is absolutely contraindicated, and UBT has to be used.
Right. Any role of hemacin? Colloidal
About
solution.
colloid, the evidence says that if the blood is getting delayed due to some reason, then you should use colloid. There are various RCTs which has weighed this normal saline ringer lactate with colloid. There was no added benefit of colloid or normal saline or ringer lactate. So today the normal saline and ringer lactate are the best IV fluids to be used. But then if the blood is not coming, then you can, and patient is in shock, then you may have to use colloid.
Before shifting the patient, PS examination must be done to rule out any traumatic PPH. Is that what is recommended?
As soon as you detect PPH, the first thing you do a PS, PV and local examination. So that is the first thing, the supportive measure, which I told later after the first bundle approach actually. But then you can always use supportive measures first, and then or you can use it simultaneously. You must do PS, PV examination of each and every patient. Rather, I suggest you to do it a second check. After the bleeding is controlled, you go for a second check.
Okay, great. Carbitocin in PPH management?
Yes, it is not available with us, but then yes, carbitocin can be used.
Important.
It is a heat labile thing, so definitely better than oxytocin, because you know we had a hot summer and availability of refrigerators is very big issue in peripheral. But carbitocin has definite more advantage over.
Okay. Importance of fourth stage of labor, intensive monitoring for bleeding and vitals.
It is said that you have to monitor the patient every 15 to 20 minutes for 2 hours. You have to do it. There are various score, the MIO chart is there. There are various tools to do the postpartum monitoring. And it has to be extensively for 2 hours, then, and in high risk cases for 4 hours.
Okay. SR cannula, can it be left in situ for how many hours maximum?
I think sir can answer it.
Who's there to answer?
Bala, sir. Bala,
Dr. Bala, are you there?
Ma'am,
Dr. Bala, if you are there, you
SR
can
cannula can be left in situ for how many?
You can take next question. Meanwhile, I'll unmute him.
Yeah. Methergine, how many doses can be given?
0.2, 5 doses can be given, but then it has to be given 2 to 3 early. The evidence says. So usually we give 0.2 mg, 0.4 mg IV, and within half an hour we repeat 0.2 mg. But the evidences doesn't favor that. Evidences says you give 0.2 mg intramuscular every 2 to 3 early for 5 doses.
Yeah, Dr. Bala has already answered the question. He's already mentioned 12 to 24 hours you can give the.
Ma'am, he's unmuted, trying to speak.
He's already answered in the chat box. Swati.
Okay.
He has mentioned that SR cannula can be left in situ for 12 to 24 hours. He said we usually shift the patient to the ward with the cannula in situ. That's his answer. Retained placenta with bleeding, is it helpful to use carboprost injection?
Yes, carboprost anyways we can use it. We can use it every 15 to 20 minutes. And even in retained placenta, we can use it.
What is your opinion? Intrauterine oxytocin during LSCS as a prophylaxis? Uterine oxytocin? No,
never. Should not use.
I think at least serum can be safe for cross-match, if not cross-match at all in all cases. What is your opinion?
Cross-match, as soon as you put a first intracat, you draw the sample and you draw a sufficient sample so that you send all the investigations, including CBC, KFT, LFT, coagulation profile. So many times we come across in such cases like massive hemorrhages which are transferred from outside, and we don't get enough sample to get the blood group and cross-match. So we have to go for this venesection and CV line, CVP line, central lines to get the sample.
So do you mean we should not reserve a single bag of even normal routinely that we reserve for all our patients before delivery? We should not reserve in a bag of blood for such patients?
For high risk cases, yes, but then not for every case.
Yes. So legally that can be a problem if we do not reserve blood in advance. There have been cases.
In private we can always justify it. Like if it is a 11 gram, 12 gram patient, no complication, then no need to reserve it. You can always defend it in the court. But then high risk cases, yes, we must.
Okay. Methergine for treatment, is IV route and prophylaxis? No, I think we have taken that. Is there any role of botropase?
Tranexamic acid is better than botropase, but then you can always give botropase if Tranexa is not available.
Okay, there's a personal comment for you, Dr. Ashish. You're looking great in this new avatar.
Oh, thanks to COVID. It is all because of COVID.
Great knowledgeable presentation by a genius personality. That's a compliment for you.
Oh, thank you.
The methadone interval you've already covered. Role of IV oxytocin bolus, you have already covered that. Many are asking about use of tranexamic acid in all cesarean cases. Do you use?
No, not in all cases we use, but then in some high risk cases who are prone for PPH, then we may give tranexam free of.
Okay.
But then evidence says tranexamic acid has to be used after PPH.
Okay. Is uterine massage included in AMTSL?
Yes, the AMTSL has 3 components: oxytocin, control contraction, and uterine massage. So the now control contraction is like evidences say that you may use it if you had expertization available. It should not be used at a peripheral level like by an A&M or somebody who is delivering a medical officer who is not trained in manual removal of placenta. So it is an optional thing. But then massage and oxytocin is the compulsory component of AMTSL.
Right. Though Dr. Bala has commented that though we can repeat methadone up to 6 doses, we have to alert and get the OT ready as soon as we've given the second dose.
So the OT has to be ready, like I told you, yeah, it has to be ready all the time. Surgical management should always be there in your mind whenever you are managing the patient with bundle, and at any point of time you can take a decision to go for a surgical management.
Okay. Is calcium gluconate useful in PPH?
No.
Okay. Do we give PRBC alternately with FFP in massive blood loss?
In massive hemorrhages, you have to give blood, and you have to give, I mean, you can give like blood as well as FFP. Alternate you can give, no issues. Or you can give blood from one side and FFP from other side.
Okay, you said packing is contraindicated. Why can we do packing with if UBT is not available? Any medical legal complication if we use packing and the balloon is not available?
So nowadays we are talking of respectful maternity care, and the packing is WHO says that the packing is the worst thing to be done to a female. So packing packing a vagina is not at all recommended, even in like for tears or traumatic PPH. It is not recommended, although we are doing it in some cases. But uterine packing is absolutely should not be done.
Okay, so just like Panigra's cannula, someone has mentioned, SR cannula is a Samarthram cannula developed by Dr. Samarthram. Okay. So again, lots of packing called what technique is outdated. Okay, so everybody's supporting your statement. Again, someone is asking to share the tabulated slide and PPH bundle slide that we will at the end of this question answer session. After delivery, immediately per speculum should be done. It will avoid missing out on any trauma.
Yes, of course. We must do per speculum immediately as soon as PPH is diagnosed.
Okay. Dr. Hina wants to know what is MEOS, MEOS score in monitoring.
That is early obstetric system, the maternal early obstetric warning system. There is a W in OS, in between O and S.
Okay. Sir, do you routinely give thromboprophylaxis for all high risk following PPH? And if so, for how long after PT is stabilized? After the patient is stabilized?
So if patient had some other comorbid factors like obesity and she had underwent an LSCS or some obstetric hysterectomy, then we may give it. So we individualize the case. But in all cases, we don't give.
Intrauterine methergine LSCS, do you give? Intrauterine methergine, do you give?
Nothing like that. No, you should never try such things. Intrauterine methergine, intrauterine prostadine has been proven, but then you have to be cautious that it doesn't go intravenous.
For a patient in atonic PPH with DIVC, does your PPH protocol differ?
DIVC is? DIC. So,
does your PPH protocol differ?
If the patient DIC like due to hepatic failure or patient had abruptio placentae, then you have to go with a massive transfusion protocol. So you have to give blood, FFP, and platelets in 1:1:4 ratio. There are various protocols which are used for massive transfusion, but then we follow that 1:1:4. And if the patient is having atonic BPH and then she went into first dilutional coagulopathy and later consumptive coagulopathy due to loss of all blood and blood products, so then this same protocol is applied.
Okay. Dose of botropase you don't give, no? You give only injection tranexamic acid. Botropase?
Yeah.
You give
Tranexamic acid.
tranexamic.
Only tranexamic acid, no botropase. But if it is not available, then you may think of botropase.
What is the dose in that case? Can you?
I never used
don't use
botropase
it.
actually.
Fine.
It was available long back in
Yeah.
GMC, but then it's not really available with us.
Dole of delayed cord clamping included in AMTSL?
Delayed cord clamping should be practiced. It is a part of our respective maternity care, and applying the baby to the breast is to be practiced for reducing blood loss.
Great. What is the time period of first and second bundle, and then shift the patient to surgery if it doesn't reduce PPH?
So there is no fixed time. Only thing is that you have to use first bundle as soon as you diagnose PPH. So the diagnosis of PPH is the starting point of using of first bundle. Now about second bundle, the failure of this first bundle is the starting point of second bundle. So you can go for compression measures and uterine balloon. And now this hemorrhagic shock, presence of hemorrhagic shock. You know the symptoms and signs of hemorrhagic shock. Patient is getting tachypneic, patient had tachycardia, she had hypotension, she's getting dyspneic, she had some loss of consciousness or something like that, she's shivering, she had sweating. So all those symptoms and signs, that is a sign where you start, that is a time where you start putting an NSG. So
right. That's, I think, just some query about probably legally when tubectomy is to be done after correction of PPH. Can it be done after correction of PPH? Maybe a medical legal question probably.
Usually in our setups we avoid doing tubectomy. It is an elective procedure, so we can always consult the patient. So never go with a elective surgery like tubectomy with any of the presence of comorbidities.
Correct. When do we massage, before or after removal of placenta?
Of course, after removal of placenta.
Again, someone wants to know the PPH trolley checklist. We will show it. Active massive transfusion protocol if you suspect DIC. Activate.
Yes.
Dr. Bala has only mentioned you should activate massive transfusion protocol.
Yes, of course.
The standard, again, that's about packing.
So you should not wait for DIC to activate the massive transfusion protocol. Once the 2.5 liter of blood is lost, you have to, that is a time when your active, this protocol should start. You should not wait for the DIC to set in. Once the DIC is set in, things are out of your hands.
Right. Should we give FFP before delivery in case of a HELP syndrome with deranged INR? Is it useful to prevent PPH?
Yes. So if the INR is deranged, especially in severe PIH or in HELP syndrome, use of pre-delivery, pre-surgery FFP is all there. You must use FFP liberally in these patients. Yes.
Right. When we give blood transfusion, should we give injection calcium and sodium bicarbonate?
We give calcium after like 4 or 5 blood transfusions. After every 4 and 5 blood transfusion, we give 1 dose of calcium gluconate.
After 4 to 5?
Yeah.
Okay. Is it a silicone catheter in UBT? Is the catheter made of silicone?
No, it is a PVC catheter. It's not made of silicone.
If thromboprophylaxis is to be used, what is the time interval after delivery and when can it be started?
After 6 hours. If you really want to give thromboprophylaxis, 6 hours is the best time.
Minimum platelet count before giving LMWH? What is the guideline?
It depends, like for what indication you want to use LMWH. But like if the patient is having already a prosthetic heart wall and you want LMWH, then you may use it even with 50,000 platelets. But then it actually depends which condition you want to use LMWH.
And in PPH, should we give whole blood or packed cells?
Whole blood is nowadays absolute. Nobody says you give whole blood. You always have to use packed cell.
Okay, but when the patient is deteriorating, can we replace volume with whole blood when you wait?
So you have to control the bleeding. If the bleeding is controlled, then you can give n number of IV fluids. That's not a problem. But if bleeding is not controlled, you have to be cautious in giving IV fluids.
Yeah, I think this is the last question. Can we use ethamsilate if Tranexa is not available?
Yes, we can.
Okay. So I think you can just show them the PPH slide and the PPH tray that they wanted to just share the screen. You can take the screenshot. We are sharing the screen again. ये baby इसमें slide. Please, everyone, please mute yourself. So this is the slide, right, for NMTSL. Everyone can take screenshots. Then we'll move to the next slide.
On the back side of this chart, we had another chart which is actually talking about the non-clinical components of bundle. So I think that is there in the video.
Okay, so we can go to the video after this. There was one more slide they wanted to see, PPH slide.
Checklist.
Yeah, the checklist slide, yeah. इसको minimize करके. Yeah. So is the bundle checklist. Please take a screenshot.
You can do a checklist on that chart itself. If like many times this, you have to keep those charts. We have placed these charts at every labor table. So like there is a PPH, we had around 4 labor tables down and 4 upstairs. So this is all there in the labor table, and over this charts only we do the checklist.
Okay, now any slide in this presentation or just the video? Okay, we'll go to the video and show you the PPH tray again.
आवाज नहीं गेला सुद्धा काही समजलं नसेल रील मधला व्हिडिओ आवाज
पहिले बोलले नाही.
स्वातीने बोलले नाही स्वतः माहित नव्हतं का?
I don't know. Yeah, so is it clear?
फोकस किया नहीं अभी नहीं ना फोकस किया बाद में उसने
या और थोड़ा आगे जाओ शायद अभी भी क्लियर नहीं
बाद में फोकस किया और एक बार और बाद में एक बार और फोकस किया.
Yeah, we are trying to freeze the slide where it is clearly focused. Just hold on. Yeah, now we'll freeze her. Just hold on. Yeah, pause. Yeah, now that's a clear slide. You can just take a picture.
Sir, if you can just read out the drugs and the disposables one. They are not.
Pitocin, you must have pitocin. Pitocin has to be kept in the refrigerator. Injection methargine, the carboprost again has to be kept in the refrigerator. POS, that is tranexamic acid. 5 ampoules, vitamin K, injection dopamine, noradrenaline, labetalol, hydrocot, soda bicarb, botroclot, then ringerlactate, normal saline, Haystar, sterile gauze, IV set, 3-way cannula, intracat, especially the 18 number gauze 2, BT set, Foley's catheter, Eurobag, disposable syringes, butterfly stickings, uterine balloon tamponade, disposable delivery kit, absorbable cotton sheet, plain bulb, EDTA bulb, and of course, if you had an NASG, NASG has to be there.
Right. Anything further to be shown in this video?
No. Checklist of this PPH.
हाँ, so अभी है और?
हाँ, इसके बाद.
हाँ, please. थोड़ा आगे. Yeah. Is this the checklist?
Yeah.
Yeah.
ये भी दिखा सकते हैं.
नहीं अभी क्लियर नहीं क्लियर नहीं थोड़ा have you focused on that later?
नहीं उस पे ही अभी है बस इसी को बस कर
maybe you can just read out. Yeah, stop.
So additional best clinical practices, I told you about prevention, then first response, and about the response to refractory PPH. So early recognition of bleeding is very important. Then we must do lab tests, we must give tranexa, and we must do the vital monitoring. And response to refractory PPH, we have to inform you have to continue your first bundle approach while giving while doing response to refractory PPH. And surgical management has to be thought. It has to be kept in mind, and you must go for compression sutures or like the all principles of surgical management. And then the last is element critical for implementation, that is network integration. The initiative started by Vaidehi ma'am, like it's a very good initiative. We must take use of it. And then teamwork communication. We have to form our own team at our local level. And the roles has to be assigned. Who will be the obstetrician? Everybody becomes obstetrician, then the problem is not going to solve. And then the quality assurance and compliance and facility readiness.
Yeah. All right. So I think we still had just 2, 3, 4 questions more. I'll just check up if I've missed out on anything. Can you? Okay,
There is a eclampsia list. If somebody wants to see, yes, we can have we had
that's in the
list.
pipeline. The eclampsia drill is in the pipeline. I think we have covered with all the questions. It was a fantastic presentation, Dr. Ashish. We have really thank you from the bottom of my heart. People are congratulating. The chat box is flooded with compliments for you. So thank you so much. There's one more message. Just let me check. Yeah, okay. I would like to tell the viewers today that the next session in PPH is going to be surgical management of PPH, part 1 and part 2. So we are going to have 2 sessions in surgical management. So please stay tuned for that as well. Okay, so this presentation is over. I hand over the further proceedings to Swati.
Thank you, ma'am. Thank you very much. Sir, congratulations and thanks a lot. It was a wonderful presentation. There's some distance. And sir, surely this PPH nightmare, you have covered it very well. Now I would like to invite Rashi Sengupta ma'am, our secretary, for her vote of thanks.
Thank you, Swati. Am I audible?
Yes.
Yes, ma'am.
Hello?
Yes, ma'am, you're
Thank
audible.
you, Swati. I would like to thank Ashish, who has been my dear friend and colleague when we were in GMC together. It was a superb lecture, and it is very evident from the number of congratulatory messages that are in the chat box. I hope after this session you have time to go peacefully go through all of them.
Thank you, Rashi.
Very well deserved and very well new points you have told us about the ESM UBT, about the dose of methergine, not packing the uterus, blood components, and most of all communication between the team as well as with the relatives of the patient. I think these are some very salient features which help us manage such an horrendous entity like a postpartum hemorrhage. Really, thank you very much for a wonderful session, Ashish. And would like to thank audience who has been logged in since 4 o'clock and eagerly waiting to have your talk started. We had more than 450 participants today on board.
Massive.
And actually nearly 400 were still listening till the end of the question and answer session.
Yes.
So I guess everybody was interested and appreciated your talk a lot. And once again, our sweet Swati Sarda for her efforts and hard work, humbly and quietly working and constantly telling me, kuch nahi ma'am, kuch nahi ma'am. So thank you so much.
We are a team, ma'am. We are a team. Thank you. We are a team, ma'am. Thank you so much.
Madam has already told we will be having sessions on surgical management of PPH also. So we'll be notifying you further. Please keep logging and listening Digi O Gyan CMEs. About the ICOG credit points, I have put up a number in the chat box. Kindly note down that number and please send your details